The practice here, the people here, the staff, the physician are great. I had my first meeting and Dr. Curry told me about the program. He didn't talk about surgery at all. He talked about the program. He talked about you come in and everything you need is here. We've got a dietitian, we've got a psychologist, because most people need counseling to deal with their emotional eating as well as just the weight loss itself.
In this next section, we're going to talk about the procedures that we can offer you to help you lose weight and improve your health. There are two categories of operations: restrictive procedures and malabsorptive procedures. In a restrictive procedure, we simply reduce the size of your stomach so that you get full on smaller portions after surgery, but you still absorb every calorie you consume. You just consume fewer calories because you're getting full earlier. In the field of restriction, we have two operations: the gastric band, that also includes the lap band and the realized band, and the vertical sleeve gastrectomy. Because these operations are simpler than malabsorptive procedures, they carry a lower complication rate, and in some cases we can offer them to patients with a body mass index as low as 30. Malabsorptive procedures are a little more complicated. We also incorporate a restrictive component, so we do something to reduce your portion size, but we also take another step to bypass some small intestines so that you don't absorb every calorie you consume. In the field of malabsorption, we have the duodenal switch, which is the most aggressive surgical weight loss procedure. Because of the risk of this particular procedure, we do not offer it, but we do offer laparoscopic gastric bypass and single anastomosis or mini gastric bypass. So first, let's tackle the restrictive procedures and talk about the gastric band. There are two bands that are FDA approved in the United States, the lap band and the realized band. Gastric bands are the only adjustable procedures, and they are also the only procedures that are easily reversible. Here's a picture of a gastric band. Both lap bands and realized bands go on the stomach in exactly the same place, and the reason they work is they help you feel full earlier, because when we inject some saline into the port on the band and we tighten down the band itself, it causes you to fill up the top portion of your stomach first, and this is where we have some complex stretch receptors located that give our brain the feeling of fullness. So when you have a band in place that's properly adjusted, you can feel full on much smaller portions. If we look at the pros and cons of gastric banding, probably the biggest advantage is that it's a very low risk procedure. It has by far the lowest short-term risk of all of these operations. Gastric bands are adjustable and reversible. They're not designed to be taken out, but some people really like to know that should something happen down the road, it's easily removable. The facility stay is the shortest of all operations for gastric band. Most patients are on their way home just a few hours after surgery. Faster recovery is possible with gastric banding, and you don't have to take as many vitamins after surgery as you would for a malabsorptive procedure. And lastly, for patients who are self-pay and don't have insurance coverage for bariatric surgery, it's one of the more economical options. If we look at the downside, weight loss is a lot slower with gastric banding than it is with the other procedures. Some patients like that, some patients don't. But typically, if we see 1 to 2 pounds of weight loss per week, we're happy with that, and it's not a race, it's more of a marathon with gastric banding. Next, there have been some studies that show less weight loss with gastric band than with the other operations, especially for patients who have a higher body mass index. So that's something to take into consideration. And then lastly, the gastric band is a foreign body. It's not your own living tissue. And really all of the complications that result from gastric banding are due to that fact. The most common complication is slippage of the band, and this happens in 1 to 2% of patients in my practice. This means that the band slips down too low on the stomach, and a patient who gets a slip will know it because they'll have the sudden onset of a lot of vomiting and heartburn issues. Typically, band slips can be fixed, but it does require an outpatient operation to reposition the band. Infection is rare, but it's a risk anytime you're using an implantable device, whether it's a lap band or a pacemaker or an artificial hip, but this is very uncommon. Erosion is more serious, but much less common than these other complications. This means that the band wears a hole through the side wall of the stomach so that part of the band is actually inside the stomach. This is not a life-threatening complication, but it's a serious one because the only way we can get an erosion to heal is to remove the band. Problems with the access port or the tubing are uncommon and very minor when they happen, like a kink in the tubing or perhaps a leak from the port. The risk of death from a band is extremely low. It's 0.05% or 1 in 2,000, which is about the same risk as gallbladder surgery. Here's the incisions for gastric bands. You can see that there are 5 small incisions. They're either 1/2 inch or 1/4 inch in length. So if you were to line them up end to end, it's about 2.5 inches total length of incisions. The operation itself typically takes less than an hour. As I mentioned, the facility stay is very short. After gastric banding, you'll be able to go home pretty quickly. Back to work is typically 3 to 7 days unless you have a heavy lifting job, and then we advance your diet slowly after surgery. You're going to be on liquids for 24 hours, pureed food for 14 days, and then you'll start on soft solids. The first band adjustment happens about 1 month after surgery. Initially, when we put the band in, we don't really put any fluid in there because we don't want the sutures to be put under any stress where we stitch the band in place. We want to give them some time to heal. And it's very important to realize that if you choose a gastric band as your operation, you really need to have frequent follow-up visits, especially in the first year after surgery. Most band patients will get at least 6 or 8 adjustments in the first year, and then maybe 2 or 3 in the second, and then typically yearly thereafter. The adjustment process is very simple. You just come into the office and we'll put you on the exam table, we'll locate your port, we'll spray the skin off with some freeze spray to numb up the skin, and then we just pop a little needle into that access port and inject some saline, and typically the whole process only takes a few minutes. But it needs to be done a number of times to get a patient restricted properly so that they're getting full on small portions and their weight loss is going along at a rate of about 1 to 2 pounds a week. So the second procedure in the field of restriction is the sleeve gastrectomy. This is overall a newer procedure. It's been done for about 8 to 10 years as a standalone operation, and it's currently the most common surgical weight loss procedure performed in the United States. The sleeve is part of the duodenal switch, the operation that I mentioned earlier that I don't like because of the risk. The sleeve is just the upper portion of a duodenal switch where we only focus on the stomach, whereas with a duodenal switch we do a sleeve plus we bypass a significant amount of small intestine. With the sleeve as a standalone operation, there's no intestine bypass at all. What we do is we make a narrow tube out of the stomach and we remove the remainder. What this does is it helps the patient get full on very small portions after surgery, and also taking out that part of the stomach that you see in the diagram there results in significantly less hunger after surgery because many of the hormones that make us feel hungry are made in that part of the stomach. So when we take it out, those hormones become much lower in your bloodstream and hunger is significantly reduced after a sleeve. If we look at the pros and cons for sleeve, I think the sleeve probably offers the best in appetite suppression of all of these operations because of the mechanism that we just discussed. Sleeve patients have very few types of foods that they don't tolerate after surgery because we're not putting a device in there as we are with a gastric band, and we're not bypassing any small intestine. There's no implantable device with a sleeve, so you don't have to worry about some of the long-term risks like slips or erosion. The risk of a sleeve is lower than the risk of a bypass, yet the rate of weight loss and the total weight loss is very close for the two procedures. And then lastly, the follow-up regimen for a sleeve will not be as intense as it would be for a gastric band where you have to come in and get it adjusted frequently. As far as the cons go, as I mentioned, it's a newer procedure. Initially, when we started doing this operation, many insurance companies considered it investigational, We've pretty much passed that stage now, but there may be still a few payers that don't cover sleeve because they deem it investigational. This operation is not adjustable and not reversible. Some patients like that, some patients don't. It's up to you to decide on which side of the fence you fall with regard to that. The complications that we worry about after sleeve are on this slide. The most common one is the issue of staple line leakage, and even though it's the most common, it doesn't happen very often at all. We see this typically in about 1 to 2% of patients. What this means is that when we do a sleeve, we have to use a complicated high-tech stapling device to do the operation, and those staples seal off the stomach, as you saw in that previous diagram. In 1 or 2% of cases, typically we see, like in the second or third week after surgery, one of those staples doesn't heal properly, and then the patient will present with what we call a staple line leak. This is not a life-threatening issue as long as it's treated properly, and typically it does not require surgery to correct, but when it happens, it does usually take a month or two to get a patient fully healed up and back to normal. Next, with regard to heartburn, sometimes we see worsening of heartburn after a sleeve. Sometimes it gets better, sometimes it stays the same, but with the sleeve in particular, we can see it worsen, whereas with gastric band and gastric bypass, typically we see resolution of heartburn. Obstruction of gastric tube is an uncommon complication, which basically means that the sleeve kinks or maybe swells a lot, and the patient might experience more vomiting than usual after surgery. The risk of death is somewhere between 0.1 and 0.2%, which is really still very low considering the rate of weight loss that our sleeve patients see and the rapid resolution of many of their weight-related medical problems like diabetes, sleep apnea, and high blood pressure. The incisions for sleeve gastrectomy are basically the same as what we saw for gastric band. The only difference is that there's no device inserted as there is with a band. The operation typically takes an hour or less. Many of our patients are able to go home the same day after sleeve gastrectomy. Typically we see a 1-day stay at the most. And then we advance your diet in the same phases as what we looked at for gastric banding. They're just longer. So after a sleeve, you do 7 days of liquids, 21 days of pureed food, and then you'll be on solids at the beginning of the 4th week. Back to work is usually in 7 to 14 days, and the follow-up regimen after a sleeve typically involves an office appointment roughly every 2 to 3 months for the first year after surgery, and then yearly thereafter. Okay, then lastly we have the malabsorptive procedures. First, we'll talk about the Roux-en-Y gastric bypass. This is what most people think of as a full gastric bypass. What we do with the Roux-en-Y is we help a patient get full on smaller portions by disconnecting the top part of the stomach and making a small gastric pouch. So after a gastric bypass, in order to feel full, you don't have to fill up the entire stomach, just the pouch at the top. Then the malabsorptive component of the operation is done by taking the small intestine and dividing it about 2 feet downstream, making a connection there, and then pulling the other end up and connecting it to the gastric pouch. This causes the patient to absorb fewer calories because the digestive enzymes that we need to break down the food we consume and absorb it are made at the beginning of the small intestine. And you can see that after this operation, the digestive enzymes are kept separate from the food that you consume until they both reach that connection downstream where they mix together, and then the food begins being absorbed normally at that point. But bypassing that roughly 20% of small intestine theoretically helps a patient absorb 20% fewer calories from what they consume. The single anastomosis gastric bypass, or mini gastric bypass, is a newer version of the full Roux-en-Y gastric bypass. It's sort of a hybrid procedure. You might consider it half sleeve, half bypass. The reason it was developed is to try to reduce the risk of a full gastric bypass with the same weight loss results. And actually there have been some studies that show that the mini gastric bypass might have as good or better weight loss than a full gastric bypass. But you can see in the diagram here, with a mini gastric bypass, we don't divide or cut the small intestine at all. We just make sort of a sleeve out of the top of the stomach, and then we pull up a loop of small intestine and connect that sleeve directly to the intestine. So there's lower risk because there are fewer connections to make, if you will. One complication that is potentially possible after a mini gastric bypass is the issue of bile reflux. You could see that it would be possible if the bile in the small intestine were to reflux up into that sleeve and maybe even make it all the way up into the esophagus. It might cause some heartburn issues, not from acid, but from bile. If we look at the pros and cons for gastric bypass, the biggest advantage is that both these procedures that I just discussed offer the best weight loss of all of these operations, both in the short run and in the long run. The speed of weight loss is also fastest with gastric bypass. Many studies have shown that gastric bypass gives the best chance for resolution of diabetes, and at least the Roux-en-Y gastric bypass is the most time-tested of all of these operations we're discussing today. On the downside, gastric bypass is the most complex of all these procedures, therefore the risk is a little bit higher than it would be for sleeve or band. Vitamin deficiencies are sometimes an issue after gastric bypass because of the bypass small intestine. Gastric bypass patients are occasionally subject to ulcers that can occur between the connection of the stomach to the small intestine, and gastric bypass is not adjustable and not reversible. Lastly, I want to talk about something called combination therapy. Our practice has a unique experience not only with surgical weight loss, but also we have extensive experience with medical or non-surgical weight loss. I view obesity as a chronic disease that in many ways is similar to cancer. Cancer often requires multiple methods of treatment, oftentimes involving surgery and then a follow-up with chemotherapy to treat any residual disease. So obesity is really not much different. We can tackle the problem at hand with a surgical weight loss procedure, but sometimes patients need follow-up therapy with appetite suppressants such as Adipex, Qsymia, or Belviq, and our practice has the experience in using these appetite suppressants to augment a surgical weight loss patient's success.